Stem cell transplantation isn't only about cancer, it is about other disorders of the blood, the immune system, and so I think it's relevant to people who have sickle cell anemia, who have various forms of bone marrow failure. So my mission today really is just to give an overview of transplantation, a little bit about what the procedure is all about, how donors are selected, what types of transplantations we're doing, a little bit of a message on some of the complications, and see if I can just give you a sense of what the process is all about. So what are we trying to accomplish with a stem cell transplant? In many people, we're trying to replace something that's missing or defective. Now, that could be a leukemic cell in the case of someone like Jay. It could be someone who has bone marrow failure, in aplastic anemia, where all of the stem cells are lost for various reasons. It could be somebody who has sickle cell disease or thalassemia, where the blood cells are behaving improperly. The bulk of what we do has to do with treating malignancies, though, and there are two forms of transplantation that we do. One's called autologous transplantation, and this allows us to give much higher doses of chemotherapy than we can conventionally give because we don't have to worry about limitation of bone marrow recovery. That is, under ordinary circumstances, when we give chemotherapy and you get it in multiple cycles, we have to give an opportunity for the blood counts to recover in between cycles. If the disease is very sensitive to chemotherapy, and we think we can cure it with chemotherapy, in some cases it is helpful to go up on the dose beyond the level where the bone marrow can recover. If you do that, of course, you may eradicate the malignancy, but you won't have any blood cell production. And in that case, we take some of the stem cells out of the bone marrow. We'll talk a little bit about what stem cells are in a moment. Freeze them, save them, give the high-dose chemotherapy, and then give them back. Sometimes you can't do this with your own bone marrow, and then we can use somebody else's bone marrow or stem cells, and this is called allogeneic transplantation. It can be done in that fashion where we give a very high dose of chemotherapy, or it can be done in a lower intensity way. This is true particularly for older people or people who have what we call comorbidities, that is heart, lung, kidney problems, who we don't think can tolerate the high intensity regimens. We can give a lower intensity regimen and actually recruit the immune system of the donor to attack the malignancy. And that is something that is relatively new over the course of the past 15 years or so. When I was starting out in this business back in the early 1980s, if you were 35, that was about as old as we could go with a transplant because we were worried about just the toxicity of these high-intensity therapies. And now we're doing people into their mid-70s relatively routinely. These other two bullet points here, organ graft tolerance is something that hasn't really quite made it to general use, but you can use bone marrow stem cells to help prevent rejection of, for instance, a kidney transplant. And I'm sure most of you have heard about Chernobyl. Transplantation was used in an effort to treat some of the radiation accident victims in Chernobyl. In that context, it's not very successful. Most of those people actually had thermal burns as well as radiation burns. But in other circumstances where the person is otherwise well, transplantation can be used in that fashion. So autologous transplantation is straightforward. You have your own bone marrow, and we don't have to worry so much about that. But for people who are getting a donor other than themselves, then we have to be aware of donor availability. We would prefer to use a matched sibling, a brother or a sister who's compatible, but in the United States, the family size is relatively small. It turns out there's only 1.2, on the average, 1.2 children per family in the United States, and this gives us the likelihood of finding a match amongst a sibling of 29%. So that means about 70% of people don't have family members that can be potential donors. In addition to that, as patients age, their siblings age. Of course, if you're 70 years old, the bone marrow of a 70-year-old healthy donor is not really what we're trying to reestablish. And so we often will disqualify older people from donation. Therefore, we need to find an unrelated donor as well. The donor registries are somewhat limited by ethnicity. Most of the people who are in the registry are people who are people who are safe, people who don't have to worry about financial issues, and so they can take the time off to donate, and they think about these things. And so that does limit to some extent who we can anticipate finding in the registry. Most of the donors available are from Western Europe. So we have spent decades trying to work on identifying or developing ways to utilize mismatched donors, that is, donors who in the past would have been disqualified as donation because they weren't fully compatible. But if we can overcome some of those barriers, then we can increase donor availability rather substantially. And increasingly in the last few years, this aspiration has come to fruition. So mismatched family members can come from a number of different places. Children can donate for each other, or siblings can donate for other, but a child can donate to a parent. Parents can donate to children. We can use grandparents. We can sometimes use nieces, nephews. We can even occasionally use step siblings. So this has really increased our ability to find a potential donor. We're still preferentially choosing matched donors, but mismatched donors can now be done fairly safely. We tend not to use mismatched unrelated donors if we can avoid it. There are some times when we still have to do that because somebody doesn't have a family member who's well and healthy and capable of donating, but that's something that is avoided if possible. Umbilical cord transplantation you may have heard about. When infants are born, some generous women and men, I guess, have opted to donate their baby's umbilical cord blood to a registry. That cord blood is taken after the umbilical cord is cut. The blood is drained out of the placenta. And it turns out that there are adequate numbers of stem cells in the cord blood to do a transplant, at least for relatively small people. This is used a lot in children, but it can be used in adults as well. And those stem cells are sent to a cord blood bank where they're frozen in liquid nitrogen and kept in suspended animation, essentially permanently, and can be used for transplantation as well. So if we have a donor, what else do we need to do? We've got a source of the stem cells. We need to make some space for the graft. So all of us in our bone marrows have stem cells that live in what's called a microenvironment. That is, they live in a supported niche where the surrounding cells provide signals, they provide nutrition, they provide general supporting structure so that the stem cell can survive and reproduce and produce blood cells, right? These cells are there to reconstitute your blood. Blood cells have a limited circulation time. That is, red blood cells will only last in the circulation for an average of about a month. White blood cells often only for a few hours, platelets just for a few days. So you're constantly making new blood cells. And this, what we call the hematopoietic niche, which is this microenvironment, this space, is how signals are transmitted to your stem cells and tell them how many blood cells need to be made, for instance. What do we need to do to maintain a healthy blood environment? Now, when under normal circumstances, those niches are filled with your own stem cells. And so if we try and put other people's stem cells in, there's nowhere for them to go. And if you do this, they'll just bounce around in the bloodstream for a while and then die. So part of what we're doing with the chemotherapy that we do for transplantation is to kill some of these, the endogenous ones. Often they have leukemia or myelodysplastic syndrome, or they're not behaving properly. We kill some of them, open up the niche. Now the niche is empty, and then when we can put some new stem cells in from the donor, they have a place to go. They can be supported. They can receive the proper signals for proliferation and reestablish blood cell production. Now, when you do an autologous transplant, you don't have to worry about problems with the immune system, but when you do an allogeneic transplant, that is a transplant using somebody else's stem cells or bone marrow, we do have to prevent graft rejection. Now, fortunately, when most of the transplants we do are matched, and that makes the rejection issue much less problematic, and the chemotherapy that we give suppresses the immune system adequately, so we don't have to worry too much about graft rejection. But the opposite side of that coin is something called graft versus host disease. All of our immune cells right now are circulating in our bodies looking for things that don't belong there, right? They're looking for bacteria, they're looking for viruses, they're looking for molds or yeast that are circulating in the, that may be in your bloodstream or on your skin or in your intestinal tract or between your teeth or wherever when you get a cut. So they're looking for things that they don't recognize, and when they identify them, they attack them and kill them, and they generate an immune response. Well, when we put somebody else's bone marrow in who is not fully compatible, they may do the same thing. And so when we take those donor cells out, they don't know that they've been taken out of the donor's body and put into a new environment. And they can look around, and if they see slight differences between the donor and the recipient, they will attack on that basis, and that's called graft versus host disease. Now this is a double-edged sword. On the one hand, if these immune cells attack your skin or your liver or your intestinal tract, that's bad, and we don't want them to do that because that's counterproductive for what we're trying to accomplish. But they can also identify the malignancy, and that's called graft versus leukemia or graft versus lymphoma or graft versus tumor. And so they contribute to the anti-cancer effect of stem cell transplantation. So part of my job is to try and establish a balance to allow just enough graft versus host disease to provide this effective graft versus leukemia effect, but not so much that it causes serious problems. So how do we get these cells? On the upper left are people donating peripheral blood stem cells. The donor gets a hematopoietic hormone, a blood-stimulating hormone called Neupogen or GCSF, and then you sit there in one of these nice little recliners for 4, 5, 6, 7 hours while your cells go through this machine. I don't know if you can see this very well, but some of them have little red bags there where the cells are being collected. And it's mostly boring. It's not uncomfortable at all, but it is quite boring. They're TV monitors. I don't know if you can see the TV monitors, but if you look on the upper right, there are little televisions up there, and they play movies for you and stuff like that. And on the lower is a bone marrow harvest. I should point out that stem cells are stem cells, and people sometimes make a distinction between bone marrow transplantation and stem cell transplantation. It's the same thing. When we obtain the blood, the stem cells from the peripheral blood, it has, in the vernacular, it's now known as stem cell transplantation. When we do it from the bone marrow, it's called bone marrow transplantation. It's the same cells. It just depends on whether we collect them through pheresis, which is in the upper left, or by directly aspirating them from the pelvis, which is in the lower right. And there are pros and cons to each approach. And here they are. So in the peripheral blood, if you are particularly adverse to going to the operating room and getting anesthesia, we don't have to worry about that. It turns out that the counts do recover a bit faster with the peripheral blood, and you're providing a lot more immune cells, so that's something of an advantage. The disadvantage is that the donor does have to take the bone marrow stimulant, GCSF or Neupogen, which is in many people uncomfortable because you're really gearing up blood cell production, and it can cause fevers and some bone pain, and sometimes we have to use even opioid narcotics to control that pain. So that's not totally free of discomfort. And the graft versus host disease rate is a little bit higher because we are giving more immune cells along with it. The advantage of the marrow is you don't have to do anything. You just come in. You don't have to prepare in any way. You go to the operating room, it takes an hour and a half, but you're asleep, so you don't even notice that. Your butt's sore for a few days, but it's usually pretty manageable. There's a bit less in the way of graft versus host disease, but sometimes people don't want to go to the operating room, and there is potential risk from anesthesia. And you are sore for a few days, although for the most part, people tolerate it quite well. So I just want to go to a little bit more through what graft versus host disease and graft versus leukemia are. So as I've described, the immune system that protects us on a day-to-day basis really evolved as a defense against pathogens, right? We know that viruses, bacteria, molds, yeast are all over the place. They're all in our environment. You can pull a carrot out of the ground, wipe it off on your pants and eat it. It's covered with bacteria. Nothing bad is going to happen to you. And that's because our immune system is so effective. And typically what happens is that when a bacteria or a virus enters the body, it's detected by the immune cells. They encounter it. They have a way of decoding whether this is a serious problem or a not serious problem. They can identify the toxins. These are what are called pathogen-derived products, toxins that are produced by bacteria that cause the things like scarlet fever or strep throat. And then they produce specific signals that recruit the rest of the immune system to eradicate it. So this, when you get the flu and you feel lousy for a week, most of that is not the virus. Most of that is your immune system responding to the virus. So as your immune system expands and starts to produce inflammatory mediators, that's what causes the fever and the muscle aches and the pain, things like interferon, is what make you feel miserable. It's actually not the virus itself, but that's the process of getting rid of the virus. And if you don't have that process, that virus can then go on and cause much more serious damage and can potentially be fatal. So this is what your normal immune system is trying to accomplish. In transplantation, as I alluded to earlier, there are always little differences between the cells. Unless it's an identical twin, where the genetically, the donor and the recipient are the same person, there are always subtle differences that can be detected by the immune system. And if those differences are detected by donor cells that have remained after the what we call the conditioning, the chemotherapy that we use, that can induce rejection. And if those cells generate a response in the donor, it's called graft versus host disease. And this is what it looks like. This is a rash. It looks like the measles, actually, or a drug eruption. Sometimes difficult to distinguish from a drug eruption because people who have transplants are often on antibiotics. And this would be a moderate case. You can see in this young man that his arms is shrunk. Everything is covered with this. This is usually something that we can treat fairly effectively. But it can become much more severe than that. We do have to treat it. We would prefer to avoid it, and there are a number of strategies that we use to do that. One is that if you have a concomitant infection, it will make it worse because these inflammatory processes that I alluded to earlier as to how you get over the flu or any other bacterial infection will non-specifically stimulate the immune system to cause this problem. So simply by keeping people free of infection, we can help reduce the risk of graft versus host disease. And then there are a number of drugs that interfere with the immune system's ability to become activated. At the moment, for those of us who don't have infections going on now, the immune system is not activated. It's calm, it's resting, it's just looking for things. And when it encounters a virus or a bacteria, it becomes activated and starts to function. And these drugs, like cyclosporin and tacrolimus and sirolimus, will reduce the capacity of the immune system to respond in that fashion. And then we can sometimes give other drugs. These are chemotherapeutic agents that interfere with the ability of the immune system to expand. Not only does the immune system have to be activated, but very few immune cells will actually be available to respond to a given infection. And so they have to expand massively, hundreds of thousands of fold. And so if you use a drug like methotrexate or cyclophosphamide, Cytoxan, you can prevent that expansion, and that helps prevent the graft versus host disease. And then there are a number of other approaches that we can use as well, which are beyond the scope of this lecture. And then people still get GVHD. It's okay. Most of the time we can treat it, and not always. And so we and me in particular have spent a great deal of my career looking for alternatives, looking for various ways of preventing and controlling graft versus host disease. This is just a list of things that have been tried in the past. Most of these are not terribly effective. They all have some activity, but our best approach is really just to prevent the procedure, the GVHD. Now, I alluded to earlier that some people get high-intensity regimens and some people get low-intensity regimens. And so what do we need what do I need to consider when I'm recommending what type of transplant to do? Well, one thing is whether the person has a fully compatible donor or not. Another is whether they've been sensitized by transfusion. So people who are very heavily transfused will sometimes make antibodies to other people's blood, and that would increase the risk of rejection, and that's something that I have to be very cautious about, because if I use a donor to which there's already a defined immune response, that will result in a higher risk of rejection. We talked a little bit about hematopoietic space in the bone marrow, and then toxicity. If the patient has a history of heart attacks, has been a heavy smoker and has COPD, has been a heavy drinker and has cirrhosis, they don't metabolize the drugs properly, or the drugs which are not, as those of you who've had chemotherapy know, it's not totally directed at the malignancy. The healthy organs do get treated with these. Sometimes you have to reduce the intensity to prevent what we call off-target effects, effects on organs that are not part of the problem. And of course, we need to maintain some sort of anti-cancer effect. So the high-intensity regimens are typically used in younger people. There are some diseases which are particularly sensitive to dose intensity, to higher, more intensive doses, and other diseases that are very susceptible to immunological control. So for instance, acute lymphoblastic leukemia, we tend to have to use a higher intensity regimen because the immune system doesn't really recognize that very well. It does a little bit, but not very much. In other diseases, for instance, follicular lymphoma, is very sensitive to the immunological component, and I never use a high intensity regimen in people with follicular lymphoma because this graft versus lymphoma effect is very effective at eradicating it. And what we are doing in that context is recruiting the immune system to kill the cancer cell. And this is actually an electron micrograph. It's colorized, so that's not what they normally look like. They're usually just black and white. But this is an immune cell, which is the amber cell, and the cancer cell, which is that pink cell. And those immune cells come right up to it, and you can see it sort of attaching itself, and it's what's going to do is punch a hole in it and kill that cell. And that's what we're trying to accomplish when we do a reduced intensity transplant. And I'm just going to skip by this because I already said that. So what we know is that this graft versus malignancy is a critical factor in the cure of some diseases. And what we're trying to do is really apply a minimal level of chemotherapy that reduces the likelihood of having side effects from the chemotherapy, but allows a graft and maximizes this anti-cancer effect. And I'm going to show you an example of how that works. This is a woman who I treated a number of years ago, and this is what's called a PET scan. And if you look on the left, you see a whole bunch of dots. And they basically follow the spine. You can see a vague outline of her body there, and her head's obviously at the top, the pelvis is at the bottom. All those black spots, not all of them, most of those black spots are lymphoma. So she had a ton of lymphoma. And this woman had 4 or 5 different regimens and really never really responded very well to the treatment. And you can see on the right what happened after after reduced intensity transplant. All of those spots are gone. The dark areas that you can see there are the kidneys. The Z-shaped one, or the sort of twisted Z-shaped one, is the intestinal tract, and the dark spot at the bottom is just the bladder, which is she's excreting the dye. But you can see that all the stuff that goes up and down along the spine and the shoulders and the lungs and the liver have all disappeared now. And that's purely immunologic, because I gave her a dose of chemotherapy that was far less than what she had received with her conventional therapy. So we knew that that wasn't what eradicated the cancer. This is purely an effect of the immune system of the donor. And this is what we're trying to accomplish with a reduced intensity transplant. What we're increasingly doing is combining transplantation with drugs that target the malignancy. So this is a drug called sorafenib. And what I'm showing you here is a relapse curve. So this is the cumulative incidence of relapse. So there's a form of acute leukemia that has a mutation in it. It happens to be called FLT3 positive leukemia. So this is a particular gene that's abnormal that contributes to the development of this leukemia that can be targeted with various drugs. And so if you look at the solid line, there was almost a 40% relapse rate after transplantation. This is not something that we were at all proud of or happy about, because that meant that over the course of a year, 40% of the patients who we thought would have successful transplants ended up relapsing and not doing very well. What we learned was that if we give this drug after the transplant, it adds to the capacity of the transplant to cure the disease, and it reduced the relapse rate to 8%. So 8% is not perfect. We still have a ways to go with that, but it's substantially better than it was before. And increasingly, as these new drugs are developed, we're finding ways of identifying susceptibilities in the malignancy that we can then take advantage of by adding a drug like sorafenib or others after the transplant, when we're in the recovery phase. The disease is at its minimum to try and further prevent recurrences. And this has been just a very uplifting approach that really we've taken in the past couple of years. One of the problems that we get into is that for many years, we have thought about the relationship of blood cells and the immune system in too simplistic a fashion. We thought graft versus host disease was an all or none phenomenon. We thought that tolerance to the graft, which means that the graft and the recipient are living together in harmony, was the ultimate goal. But it turns out that there's a whole gray area in here that we have really ignored for the past decades. Well, really, we've tried to work out the technical aspects of transplantation. Excuse me. And so what you can see here is really just a reminder that there are relationships between the immune system and, for instance, normal bacteria that live in your intestinal tract, that if we can, right now in all of us, of course, most of your intestinal tract is full of stool, which is mostly bacteria. It's very little undigested food. And that bacteria is necessary for healthy digestion and healthy functioning. There is a relationship between those bacteria and good health. We know that that's true, but if you have ever had a bone marrow transplant or know someone who's had them, you'll know that they're on a ton of antibiotics to prevent infections, and it tends to reduce the flora, the bacterial component of the gut, and that is not necessarily beneficial. So we're trying to work on ways of restoring that balance so that the good bacteria, the ones that help us digest food and that calm the immune system, will be allowed, and the pathogenic bacteria are destroyed. We know that tissue repair is important, and that if you completely wipe out the immune system, some of the immune cells that are responsible for just healing of wounds, for instance, or healing of rashes, or healing of any sort of tissue injury, are not being allowed to have their full level of efficacy. Tissue metabolism and things of that nature. So this is, I think, an area that we're going to start moving forward in the future, where we're going to try to adapt non-destructive immune responses to help with healing. And I think that we're looking forward to really a new sort of generation of transplant physicians who will be focusing on this type of thing in addition to eradicating the malignancy. So where are we going in the future with this field? Well, we've been doing pretty well with increased accessibility. It really has only been the last decade or so that we figured out how to make it work with haploidentical or half-matched donors. And that has really increased our ability to do transplantation for people who have uncommon HLA types, or people who are in ethnic minorities in whom the registry is not very helpful. Cord blood transplantation was a big boon for many years. It's less necessary now. We still do cord blood transplants, but now that we can go to more extended family members because we're not so worried about the degree of compatibility, this has been quite helpful. We're increasingly using things like cancer vaccines. One of my colleagues, Vincent Ho, is running a very large study of leukemia vaccine. If you think about what we have talked about today, one of the things that we're trying to do is recruit the immune system to be more effective at eradicating the malignancy. And there is a baseline level of efficacy, but if we could expand that and make it more effective, that would be so much the better. And so by taking leukemia cells, in this case, and making vaccines with them, we're hoping to stimulate that type of immune recovery without enhancing graft versus host disease. And then there are a bunch of other things. You may have heard about CAR T cells, which are chimeric antigen receptor T cells. These are genetically engineered cells that are capable of eradicating certain kinds of malignancies. There are things like checkpoint blockade inhibitors, nivolumab, Yervoy, various ones that have been, to a significant extent, used in the treatment of things like lung cancer or colon cancer, but also are helpful after marrow transplantation because they also enhance this graft versus malignancy effect. They're designed to improve the ability of the immune system to identify and eradicate a cancer, and that's, of course, what we're trying to do with transplantation, and so they can be used in this context as well. And then I mentioned already the sorafenib with the FLT3. There are a number of other genetic injuries that are targetable with a variety of different drugs that we're increasingly studying to try and supplement the intrinsic anti-cancer effect of the transplantation with relatively non-toxic drugs that can be given in a maintenance fashion over a long period of time and further suppress the capacity of the disease to recover. And then finally, a major goal of ours, but probably the most difficult of all of these, is enhancing immunological recovery. We don't have right now a good way of making the immune system more effective. And for anybody who's had immunosuppressive chemotherapy or cytotoxic chemotherapy, and worried about going into crowds and worried about what you're eating and such, this is really a critical issue for us. It is an area of intensive research, but it has turned out to be much more difficult than we had initially anticipated. But as we learn more about the biology of the immune system, what various cells do, what subsets of cells do, what the interactions with the intestinal microbiology are, and the skin bacteria and things of that nature, we're increasingly getting insights into this. And I'm very hopeful that in the next 5 to 10 years, we'll actually start to make significant inroads here. So that's it for me. I hope that I gave you a basic understanding of what transplantation is all about, and I'd be happy to take any questions. Yes?
What is the average time afterward for the quarantine? Is that individualized for each patient, or
The average time of?
being quarantined at home?
Right. The question was, what's the average time that patients are quarantined at home? They're not really quarantined at home. You can go outdoors. What we're trying to do is avoid contact with people who might have a cold or a flu during the period in which your immune system is incapable of responding to that. As you may know, in the United States every year, something like 30,000 people die of influenza. That's not healthy people. That's usually people who have alterations in their immune system or have cardiac or lung problems, elderly, or et cetera. And transplantation recovery is thought of in that way. So what we're trying to do is protect you from viruses that we cannot treat while we're waiting for the immune system to recover. It takes a good year for the immune system to recover. Various types of transplants will have faster recoveries than others. So autologous transplantation, we generally put the restrictions on for about 6 months. For an allogeneic transplant, it's more like a year. There are centers that are more or less aggressive about that, I guess, and so there's some individualization of that. Yes? And who are they indicated? At the moment, they're not indicated at all. We're still trying to make them work, so it's really being done on a research basis. Our question was, in whom are cancer vaccines indicated? These are research undertakings, and the vaccine program that we have right now are for people with acute leukemia or myelodysplastic syndrome. And what we do is we collect some of their leukemic cells before the transplant. We are able to process them in the laboratory to make them into a vaccine. They're then frozen, we do the transplant, and we give the vaccine afterwards. If this is successful, we're hoping that this would be something that ultimately be approved by the FDA. But we don't have vaccines for all malignancies. Our particular goal at the moment is in acute myeloid leukemia and myelodysplastic syndrome. Yes. No, this gentleman first, please. Yeah, that's fine.
With stem cell transplant, do you find it, when the person getting a stem cell transplant, a higher risk of living longer, and even with a tandem stem cell transplant, or do you find it's when the person's not getting it, will they have the same amount?
Right. So the question really has to do with survival after transplantation. Our goal is to cure the disease. Sometimes we can't do that, and then our goal is to extend life. So it's a balance, and to the degree that it's effective, we have people like Jay who are completely cured of the disease, and we anticipate a normal lifespan. Other people where the disease is more difficult to cure, it would, for instance, convert a 2-year survival to a 10-year survival. And so that's okay. It's not optimal at the moment, but sometime in the next 10 years, we will undoubtedly have more effective therapies, and we can extend it another 10 years. And if we keep doing that, we'll be all right. Yes, sir.
Is there anything on the horizon, even looking 5 or 10 years down the road, that's new and radically different from the way we approach things today that is promising for a cure for this disease?
So the question is, what's on the horizon that's really radically different from what we're doing today? It's very disease dependent because they have different susceptibilities. So, for instance, lung cancer. 5 years ago, we didn't have checkpoint blockade inhibitors. We do now. They are very effective at palliating the disease. They're not so wonderful at curing it, but that was a radical change. We had no idea that you could recruit the immune system to treat lung cancer 5 years ago. We're doing that type of thing as well in other malignancies. So the chimeric antigen receptor T cells was a radical change over the past few years. We can now genetically engineer the immune system to target leukemia. So they come in bits and in spurts, and there's no lightning bolt that comes down. Every once in a while we hit something that's very effective. But a lot of research going on. Much of which doesn't take us anywhere, and every once in a while you hit a home run.
Thank you.
Yes, sir.
I was just wondering if the T cell therapy is still in experimental stage, so it's for refractory type patients.
CAR T cells are commercially available for some diseases. They are not perfect. There are a lot of limitations on them, and so we do have both a research component and a clinical component. So for some diseases, particularly for large cell lymphoma, for instance, CAR T cell is a commercial product, and you can just come and get it, and it's not done on a research basis. Myeloma is not approved yet, but probably will be this year.
Thanks, Joe.
Thank you very much.